കുഴപ്പമില്ല.
Welcome to AETCM, the Emergency Medicine channel.
Yes.
19-year-old male who came to ER with acute onset of breathlessness since the day evening onwards.
Yeah.
On arrival, initial assessment, patient was conscious and oriented. In primary survey, airway, patent, there is no pooling of secretion, no stridor or hoarseness.
Okay.
Breathing, respiratory rate is 28 per minute, saturation is 95% in room air. In auscultation, bilateral equal air entry percent and bilateral wrong gaze percent. Due to bilateral wrong gaze percent, we started on nebulization with Duvolin.
Okay. So how much Duvolin? Like what's the dose?
Duvolin and levosalbutamol and epinephrine bromide.
Okay.
Levosalbutamol is 1.25 milligram and epinephrine is 500 microgram.
Okay. Fine.
On nebulization ongoing, we continue the primary survey. On circulation part,
So what is the heart rate initially?
initial heart rate is 86 per minute.
What's the relevance of heart rate in such a patient?
In hypoxic condition, heart rate will increases tachycardia.
Okay.
Heart rate
Again,
is
we'll come to it.
86 per minute.
Because knowing heart rate at this point is important. We'll come to it again. Yeah, continue.
Heart rate 86 per minute and BP is 120 bar 80 millimeter mercury. All peripheral pulses are palpable.
Okay.
Disability GCS is E4, V5, M6 and exposure, there is no temperature, GRBS is 160. On reassessment, he is ongoing nebulization and symptomatically better.
We'll finish the secondary survey, then we will discuss. Yeah.
Secondary survey, 19-year-old known case of bronchial asthma patient.
Okay.
Only had intermittent episode of breathlessness.
Okay.
1 month back, he had acute exacerbation of asthma following by exposure to cold atmosphere.
Okay.
That day onwards, he was on Foracort inhaler
Okay.
containing formoterol 6 microgram and budesonide 200 microgram. Today evening again, he had similar episode of exposure to cold atmosphere. His breathlessness worsened and come to our ER. No other comorbidities, a family history, a mother is also asthmatic.
Okay. Fine. So now you have a 19-year-old non-asthmatic coming with an acute exacerbation, right? Okay. So in the initial primary survey and all, you feel the patient's sensorium is intact. And heart rate was also normal, but mild tachypnea was there. Respiratory rate was around 28. You auscultated and you found some minimal V's on both sides, and based upon that, you have started the patient on nebulization, which you have given is a Duvolin, which has 2 drugs. What are the 2 drugs you told? Okay, one is a SABA, short-acting beta agonist, and other is
Anticholinergic.
okay, fine. So here, sensorium was good. What are the concerns in a patient? Like, what are the warning signs or what are the alarming signs for a patient who is coming with bronchial asthma exacerbation?
If the sensorium is not good, there is carbon dioxide hypercapnia situation is there. That means the patient is going to type 2 respiratory failure condition.
Okay. So with sensorium, if the patient is becoming drowsy and all, that is definitely one concern is with CO2 narcosis. Okay, then can PCO2 go up in asthma? Then you can come in.
Yeah, it can go up.
So basically, conventionally, we think that carbon dioxide retention is more with COPD and asthma is not. But acute severe asthma, after a point, if it starts going into CO2 narcosis, then it is a significant deterioration. Okay. Only in very, very kind of refractory cases, it will go into CO2 narcosis. Okay. If at all it is there, then take it as very significant. Okay. So that is with sensorium. Okay. Then heart rate, if it is increased.
Bronchial asthma can be divided into mild, moderate, and severe condition. In severe condition, the heart rate will be more than 120. Likewise, the respiratory rate will be more than 30. And also, when we are looking up for the saturation, if saturation is less than 90, that is also severe rate. And other than that, we can also look up how's the patient's clinical condition as such on arrival. Likewise, here told the house altered sensorium or this patient is having severe breathing effort, respiratory effort. Then PaO2 FiO2 ratio can be.
I will come to that. Okay. We are talking about the heart rate here, right? So one is sinus tachycardia itself. Okay. What if you are getting a pulsus paradox kind of picture in acute severe asthma? Can it indicate anything?
Other cardiac causes of cardiac tamponade, constrictive pericarditis.
Why are we going to cardiac tamponade in bronchial asthma?
Asthma also we get pulsus paradoxes.
No. So basically what has happened is now the entity it is renamed as critical asthma syndrome. Okay, that is where you talk about all these whole terms of status asthmaticus, acute severe asthma, everything together. Because of extreme lung hyperinflation, that again can impact and result to symptoms similar to cardiac tamponade. Okay, so if the patient is remaining in prolonged kind of hyperventilation, severe bronchospasm kind of scenario, and your thoracic pressure is increasing, and the lungs remain hyperinflated, that can again lead to these kind of issues. So that's kind of an extreme kind of area, but you should also always look for the heart rate and rhythm in an acute severe asthma. The third thing will be if already the patient is having very high heart rate, say 140, 150 and all, what are you going to be cautious with your bronchodilators? What happens to the heart rate with salbutamol?
Salbutamol causes palpitation, so we avoid salbutamol.
I mean, it is the risk we need to take because that is kind of the most effective and the first line kind of drug. So always be cautious when the patient comes with a very high heart rate while giving salbutamol. Look for it going into like SPTs and things like that. So you have to be aware of that condition. I'm not saying that you should not be giving salbutamol, no. But be aware and be cautious of further worsening of heart rate. Okay. That said, at least theoretically, your levosalbutamol has less cardiotoxic effect compared to salbutamol. So that is one advantage of giving levosalbutamol in such situations. Okay. So here we have given 2 drugs. So what is the usual recommendation? Like, is both ipratropium and levosalbutamol to be given together in acute severe asthma?
Initially we give short-acting beta-2 agonist.
And what is the dose?
It is 2 to 5 milligram per kilo. 2 to 5 milligram is the dose.
2.2. It's usually 2.5 mg. And tell the whole thing, no? Nebulized over.
Nebulized over for 3 cycles are needed. 20 minutes apart, we nebulize 3 cycles. Patient is not improving.
Yeah. So that is first you give. After 20 minutes, you again repeat. So 3 cycles. Okay. That is the point at which you are going to reassess and decide on whether the patient will need a second line kind of nebulizer. Okay. So you gave salbutamol and ipratropium. You feel that the patient is better at this stage. Suppose assuming that initially when you are auscultating, you are not hearing anything. What can that indicate?
Silent chest is that indicating severe bronchial constriction is there.
Okay. So yeah. So basically, not getting any sounds can be worse than getting these. So just have that thing in mind. More like a silent line kind of appearance. No? Okay. Then continue with this. So you have given and now the patient is better. Continue.
On second cycle of Duolin, we given one reassessment because there is on clinical examination no pallor, icterus, clubbing, lymphadenopathy or cyanosis. On respiratory system examination,
can cyanosis happen in acute severe asthma? It can happen, no? Patient can go into severe hypoxemia. Again, cyanosis, as you told, he told, no, altered sensorium, increased heart rate, not able to complete a sentence, cyanosis. These are all indications of very severe attack. Fine.
In respiratory system examination, bilateral bronchi is present and improving on second cycle of nebulization. CVS S1 S2 is heard. On reassessment, we give injection hydrocortisone 100 milligram IV stat we give.
Okay. Fine, continue.
After our third cycle, patient symptomatically becomes better and observed for some time. Since the symptoms improved, we plan to discharge the patient.
Okay, so here we will just come back. So as per recommendation, you are going to give the first dose of inhaled SABA, add on with ipratropium if need be. So coming back to steroids. So what is the role of injection, that is parenteral steroids?
Ideal anti-inflammatory action is there.
Okay. Like what are the choices? Is there any superiority over one steroid over the other or anything is fine? What is the usual recommended thing? Is methylprednisolone. Okay. You have to give at least prednisolone equivalents of 50. So any steroid is fine. You can either give hydrocortisone which is 200 for 24 hours in divided doses or methylprednisolone or Dexa. Even Dexa you can give. Okay. The problem is that even if you are going to give IV steroids, when are you expecting the onset of action?
Take some
at least 6 hours. At least 6 hours. Okay. So definitely it is indicated in refractory cases, but understand that the effect of steroid is going to come later. So is there any role for inhalational steroids? So all this Budicort and everything is there, no?
IV and inhalational route is already same action. It is to prevent the recurrence.
So in acute exacerbation, definitive role is not there for inhalational. If you are giving IV, there is no additional benefit on giving an inhalational also. Okay. So now you tried all these things. Now you are into 1 hour. You have already given your IV steroids. 3 cycles of both ipratropium and levosalbutamol is over. Still the patient is tachypneic. And your ABG has come. ABG no major issues. pH is remaining okay. Hypoxia is also not that much, but symptomatically patient is not improved. What will you do?
Sometimes MgSO4 is also given.
Okay. That will be the situation definitely where you are going to consider magnesium sulfate. What's the dose of magnesium sulfate?
2 grams, which is given in 100 ml over
20 minutes. Okay. So 1 dose of magnesium sulfate is indicated at that point. Okay. So this is one scenario where the patient is reasonably fine, but symptomatic relief is not there, and you are continuing with this cycle. After this, every 4th hourly you can continue with the nebulizations, and you can wait for the steroid to have effect, and most likely the patient will stabilize. But definitely you need to rule out certain things at that point. So what has caused the exacerbation? So what are the usual triggers for exacerbation?
Most common dust mite, food energy or cold exposure, exercise, emotion.
Okay. Those are the usual triggers which probably we are not going to intervene with anything medically. But there will be certain things like bronchitis and acute infection can also trigger bronchial asthma. Those kind of situations, definitely there will be a role for treatment for the underlying trigger. Okay, fine. Now, there can be another situation where the patient is already, by the time the patient has come in to us, patient has become almost near drowsy, not able to complete a sentence. Okay, ABG has started showing PCO2 retention. So, how will you intervene in those kind of situations?
If the nebulization is not improving the patient, we give non-invasive ventilation like method. If patient is not improving.
Okay, so patient has both, assuming that the patient has both hypoxemia and hypercarbia setting in.
Type 2 respiratory.
And fine. What is the evidence regarding NIV in bronchial asthma? Like, one thing is practical thing. What is the evidence?
His respiratory effort will be reduced.
Evidence inside, what does the literature say? So basically, there is not much evidence to support use of NIV in acute bronchial asthma exacerbation. But definitely, we use it on a practical basis with advanced NIVs, and there seems to be some kind of initial stabilization which is got. Suppose the patient is ending up on a mechanical ventilator. Okay, what are the things which comes in specific to bronchial asthma? Just you can comment. What is going to be your induction agent?
Bronchial asthma, as such, so we can start with.
Now you have decided that this patient needs mechanical ventilation. Okay. Start.
Ketamine can be tried because it doesn't have any respiratory suppression or anything.
Okay.
Also, we can also try with etomidate also.
Okay, definitely. The whole thing is that ketamine will be one drug which definitely we will consider in this scenario. Okay, so now you intubated. Okay. Post-intubation, you are moving on to the ventilatory settings. What are the principles on which you are going to set the ventilator?
So here in which we'll have to, patient won't be having lot of obstruction as such. So it's a obstructive disease as such, but mostly we'll have to attain a tidal volume of 400 with
okay, fine. No problem. Our concern here is going to be expiration. Okay. So, how are you going to set the inspiratory-expiratory rate? Definitely, you are going to set a higher expiratory rate. So, your IE ratio will be usually 1:3, 1:4 kind of thing. Tidal volume, definitely you can aim for a lower tidal volume. 6 to 8 is good enough. Okay. Minute ventilation also something around 8. We can achieve. Rate, don't go for a very high rate. Usual rate is around 12 to 14 kind of rate is also good enough. Okay. So, and PEEP again, minimal PEEP. So, what's our whole thing? We don't want a kind of air trapping during ventilation. That is our whole aim. So, we want to maintain the expiration properly so that the CO2 is also washed out. Again, is permissive hypercapnia something which comes in bronchial asthma management ventilator?
Yes.
Okay. So, let us, again, what is permissive hypercapnia is where you allow PCO2 to be little high. Okay. So, along with the initial management, it is acceptable to have a higher PCO2 to maintain the oxygenation support. Okay, fine. So that is with that. So suppose we have already intubated the patient, we are giving kind of a lung protective kind of ventilation with whatever principles we have followed so far, and still the patient is, we feel that the lungs have not, the bronchospasm is still persisting. Is there any salvage kind of stuff which can be considered in tertiary care centers? Inhalational anesthetics can come in at this point. Okay, so that will be one thing which probably can be used as salvage kind of thing. And again, advanced kind of scenarios, even extracorporeal removal of CO2 and ECMO can come in. Okay, so those will be the kind of advanced kind of stuff which can come in use in refractory asthma, already patient intubated, not yet improving. Okay, right. Anything else? So we initial assessment, we kind of went through it. Investigations, yeah. What are the investigations in bronchial asthma?
Total count is
Yeah.
normal. Total count is 5,000 and
Not in this patient, in general. What are the investigations which usually comes to our mind or needs to be done in bronchial asthma?
hypoxic condition we do ABG. For
Okay, what's the role of ABG?
any severity, we look for the PCO2 is increasing, pH is acidotic site. In also there is salbutamol taking the hypokalemia to rule out any hypokalemia, because in hypokalemia patient cannot breathing difficulty increases.
Okay. Will you be surprised to have a like respiratory alkalosis in bronchial asthma? Because of PCO2 washout, it can happen. In early phases, it can happen. Okay.
Due to hyperventilation. So happen. These are the things we look in ABG. Then we do a CBCRP point of care to rule out any infection caused to exacerbation. Chest X-ray we taken.
What's the role of X-ray in bronchial asthma?
If there is some pneumothorax, to rule out any pneumothorax.
Okay.
Or any infection goes to bronchial asthma, pneumonia-like infections.
Okay. But most of the time, we might find this in hyperinflated lung. No?
Hyperinflated
Fine.
lung,
That is with X-ray. Okay. Any other investigations? So basically, for managing asthma, this is all you need to prove a diagnosis and to rule in or rule out an infection. That's all you need. Okay. Any role of Montelukast and leukotriene antagonist in bronchial asthma management?
Basically, acute onset there is no role.
Excellent.
We, give anti-allergic for 1 week or 2 weeks for prevent the recurrence.
Okay.
Then we add a short-acting patient is already on long-acting formoterol and budesonide. So for acute episode, we will add one more short-acting SABA metered inhaler for this patient.
That's it, no? Okay. I think we covered most of the aspects in acute severe asthma. No? Anything else to be added, Jaren? Okay. Thank you.